So good morning for those of you in the US, and good afternoon for those in Ethiopia. Thank you for joining us again. This is going to be a relatively brief presentation, probably about 20 minutes or so, by Dr. Elias Hashame, who most of you may have met on Friday. He presented the first presentation about introducing us to this disease. Dr. Elias is a graduate from Gondar University. He works now in the US as an intensive care specialist, and he's also an infectious disease specialist. He is a board member of the Ethio-American Doctors Group. He is, as you can see right now, currently on call and providing service actually in one of what they call the COVID units, where they see these patients and take care of these patients. We'll be also joined by the other presenters from the past and the future to add some value to the discussions. So without any further delay, I just want to ask Dr. Elias to share his screen and want to thank him for being here today to present this. And also a very important person, that is Malaku Nuguse, who is behind the scenes, who has been actually doing all the work. So I just want to say thank you to Malaku, who has been actually the engine behind all this organizational part of the webinars. So without any further ado, Elias, we can see clearly your slides. Please go ahead. Last thing I just want to mention, I don't know if you guys remember, we were kind of hacked the other day where our line was compromised. So if that happens again, what we'll do is we'll sign off immediately, and Malaku will send you a new link, and we'll sign on within 5 minutes so that we can avoid that hack. So with that, Elias, the floor is yours. Thank you.
Thank you, Gurma. Hi, everyone. Yeah, so is our presentation Mijamaro clinical management and outcome now, and I don't think it's going to be a problem. So it's going to be a brief presentation, and I'll try to make it more practical. Then the floor will be open, so we'll go to question and answers. I know some of my colleagues are joining me as well. So when we manage, so this is going to be critical care management. So it's not different from any viral pneumonia, respiratory failure. Having said that, we're learning a lot about this disease essentially every week. So I'll talk about what are the specific differences about COVID. And I know tomorrow's topic will dive deep into managing acute hypoxic respiratory failure by Dr. Morla. So mine is going to be just general management and outcome. So the principal feature is acute respiratory distress syndrome, which is defined as acute onset of hypoxic respiratory failure with bilateral infiltrate. Now, we try to talk about just evidence-based treatment guideline because there are a lot of treatment suggestions out there. Most of them are just experience-based. So this discussion will be limited to essentially what we call evidence-based. So what we do is conservative fluid strategy, as you guys know, are the main part of management of respiratory failure, especially ARDS. So once you pass the first resuscitation phase, then your fluid management has to be what we call a dry lung strategy. You try to keep the lung as dry as possible. And we'll talk about why. And empirical early antibiotics should be always part of the management, but we'll talk about that when to start and what parameters or markers we can use to help us in that decision. Of course, lung protective ventilation is the core part of management of ARDS, and I'll talk about what that means in prone positioning. So this is just a short summary of management of respiratory failure in a COVID patient. And I will not go in detail into that because I think this will be covered on my next few slides. But this is to show you what are the modifications you have to make to the usual critical care in a COVID-19 patient. Some of them relate to management of airway management, which Dr. Helen went through yesterday with infection control, and I think Dr. Dowd will touch upon that in the next presentations. And of course, the last two are essentially planning and specific treatments, which I will actually discuss in detail about the specific treatments, especially medication-wise. So high flow nasal oxygen. So I know, think my information is correct. Okay, Ethiopia, there's no high flow capability, but you can still deliver a significant amount of oxygen through either non-rebreather or nasal cannula. So that has to be I think the core part of the management. And I'll talk about why non-invasive ventilation is not good for COVID-19 patients. And I'm sure Dr. Helen touched upon that yesterday as well. The reason is because our high-flow nasal cannula is a less contained circuit than invasive management, and so there's a high risk of dispersion of the virus. But in a lot of places, I think people are using it more and more because really, I mean, that was a concern, but the data is not there, and most of these patients, you'll see that they are pre-hypoxic. So there is no. I just want to make sure clear that I think my colleagues agree that there is no FDA-approved medication at this time. So everything we use is essentially based on expertise, opinion, or experience. But we also know that mortality in this particular disease is very high. This is so if you see on this slide, all infected patients can range from anywhere from 0.5 to 4%. It could even be higher. We just don't have the data right now. Among hospitalization, mortality is even much higher, 5 to 15%. Among people who goes to ICU, that is really high. I mean, sometimes what you hear from your colleagues is concerning, because if someone end up on mechanical ventilation, and if they have poor prognostic factors like age, comorbidities, their chance of making it is very slim. This is just the data from Hubei province. It could be as high as 62%. And majority of them die of complication of hypoxia and multi-organ dysfunction. I think my prior slides did show some of the cause of mortality. So when we go to treatment, so I'm going to go one by one, and what the evidence is, what we're doing here. So steroids. So steroids, when we start this disease a couple months ago, based on prior experience from the SARS 1 and the MERS, corticosteroids were not recommended. But now, more data is coming out that suggests that they might have a role, especially at the phase of what we call it proliferative stage, or ARDS. And so a lot of facilities are using steroids as part of the treatment. And where I work, what we do is, if they have a reason, for corticosteroid, either we think they are in acute exacerbation of COPD or in refractory shock, or for any other reason, for asthma, we don't stop steroid. We continue to use them, but we don't specifically start steroid for the treatment of COVID-19 patients at any stage of their disease. So we don't do that right now. I know a lot of facilities start doing that, and the data is just not there, except that this one small series out of China did tend to show some mortality benefit, but I don't think it's convincing evidence. And so the main concern is, of course, it can increase the viral replication and delay viral clearance. So hydroxychloroquine seems to be the most popular one. And for you guys, I think chloroquine is the alternative. So we do use hydroxychloroquine. Now, the data are there? Not really. I mean, but essentially, when you are out of options, learn more over to Jamra, and this is where we are right now. So, we do use them. So we have a criteria when to start the treatment. We don't usually start them in the mild and moderate cases. We usually wait till they are confirmed. And we only tend to use them when they are in moderate to severe cases. Number one, the data is not really convincing. Number two, there is a lot of side effects to it. Hydroxychloroquine seems to be better safety profile compared to chloroquine. And I've never used chloroquine here. And we use hydroxychloroquine a lot for our, especially rheumatoid arthritis patients. So we have experience on that. But when we use them with azithromycin. And that was based on this small, famous study that came out of France. And now, so you have to be careful when you do that, because so the main concern is QTc prolongation. I think that's the main side effect. Now we're seeing also some liver function abnormalities as well, but the main concern, both of them are because known QTc prolongers, so they can go to malignant arrhythmia, ventricular tachycardia. Also, Torsad have not been seen a lot. It's very rare, but so you have to have some kind of monitoring. What we do here is we do EKG at least every other day. And of course, most of our ICU patients are on continuous telemonitoring. If you can do that, and that's one way to monitor, but EKG is the best way to do it. So Kaletra. So Kaletra was previously shown to have an in vitro activity against the earlier coronaviruses, and but this particular trial did not show any benefit. Now the question was, when they started, was whether it was too late, or was it the dose was not appropriate? Now I know it's part of the armaments now people use, and in my facility, it does need ID approval, and we don't tend to use them yet. I don't know whether you guys have I know my colleagues are here. If they have any experience, they can tell you. And I'm not a big believer of that, but I just haven't seen the convincing data on COVID-19 on Kaletra. So that's all I can say about that. Now, remdesivir is that's a real antiviral medication, actually. And this is a prodrug of adenosine analog. Gilead is the developer. And this was, I think, first manufactured for Ebola outbreak. And it does have high genetic barrier to resistance. Now, having said that, so the first few months, he was available on a compassionate basis, but I know the company has they changed, and now unless you are part of the clinical trials, it's essentially impossible to get remittance there. And I don't know whether any other way to get this. And we have used it on one patient. I don't know whether it helped or not. I can't really say that because the patient was doing okay anyway and ended up going home. But that's what it is. So this is IL-6 receptor blocker. So one of the common one is what we call tocilizumab. So tocilizumab, what it does is essentially it blocks the IL-6 receptor. So there are a lot. This is a particular case, serious, and it seems to have significant benefit, especially when they are in what we call it cytokine storm syndrome. That seems to be the main culprit of progression of this disease. So what we do is, now again, this one is a very expensive drug, and we have used it. But before we use it, though, before you use it, you have to make sure IL-6 level in the serum is high. Now, the test itself is difficult. For us, it takes about 4 or 5 days. And so if you have access to the test and the medication, you can use it. Its cousin, cosirilumab, is also another one that there are a lot of clinical trials going on here, even in the US. And I know my colleagues have used that as well. It does seem to work. And again, there is no randomized control study done. This is recommended doses. Usually, you only have to use it once. You can repeat it in 12 hours. Right now, I can tell you in my facility, there are only 2 doses. So this is hard to come by. But it does work. And again, but that's based on experience and expertise opinion and a small data. I'm going to just move this one and go to the summaries. I touched already on the search prep and flattening the curve. So in the summary, so the course of the disease is quite predictable nowadays. You know how they end up, and most of them present to you. Most of them are asymptomatic, and so the purpose of this topic is how to manage critically ill patients. So that's why I didn't spend much time on asymptomatic patients, but most of them are asymptomatic, and those who end up in the hospital tend to go home. But those who come to ICU, they seem to have a predictable course. Acute respiratory failure usually occurs in about 6 to 8 days, and again, cytokine storm and hypercoagulable state. So most of them seem to have what they call a microthrombosis, mainly in the lung and also in other tissues, including renal. So that seems to be the main pathophysiology behind worsening of this condition. And so that's so part of your management. I think I'll touch upon it is how to avoid hypercoagulable state, including DVT prophylaxis. Some people actually even start a full treatment doses. Now, that's not based on any evidence. So most of them seem to have what looks like a shunt. They are hypoxic, but clinically they don't look hypoxic. And I think the early phase of preventing progression is crucial for a lot of reasons. Number one, resource-wise, as well as if they end up in mechanical ventilation, the outcome is grave, most of them. So avoid intubation should be the aim, because once intubated, the mortality is high. And it does not behave like your typical ARDS. It actually behaves what looks like a high altitude pulmonary edema. I don't know whether you guys have dealt with that or not. The management is a little different. Those people, when they present to you, especially in ICU again, they have what looks like hypermetabolic state, they have fever, and so they are probably dry, dehydrated. So you're early on, your fluid management is a little different than your ARDS early on. So you need to resuscitate them well, especially if they are going into worsening respiratory failure, requiring mechanical ventilation. Because when you intubate them, I know Dr. Halen spent time about airway management. So when you intubate them, right after intubation, they tend to crash. Because when you intubate them, there's a positive pressure in it. So their preload is already low, they're hypovolemic, intravascularly dry, then their blood pressure essentially goes down. So you need to keep that in mind. So you have to have adequate resuscitation. And if you have the chance to do CT chest, they have some particular discrete infiltrate multilobar. I think I mentioned this to you guys. One of our diagnosis was incidental finding on the CT scan, and the patient presented with diarrhea. So, and of course, physiologically, COVID-19 ARDS seems to be different for the above reasons: the micro thrombosis, mainly, and the fluid-filled alveolar. So the management, I think touch upon is they tend to respond more to proning. I don't know whether you guys know what proning is. Essentially, you put them on their tummy, and some call it here. You guys know that there's the baby's tummy time, so we call it adult tummy time. You just put them on. You just have them even awake proning, and that does what it does is it takes the mediastinal structure away from the lung, and it gives you more space to oxygenate. Essentially, that's the reason behind it. So you have more lung tissue to work with. And the proning works pretty good on this patients, even early on. We do one of our patient. Most of his stay in ICU, he was essentially on his tummy. It's not fun, but it does improve their oxygenation significantly and avoid intubation as well. So one of the difference between this disease and the typical ARDS is in typical ARDS, the lung compliance is really bad. But early on in this lung compliance seems to be pretty good. So the hypoxia seems to be due to more shunting. And again, this takes us to microvascular disease. And pulmonary embolism, I told you guys hypercoagulable state. Keep in mind, it's very common in this patient. We do have a patient right now in the unit who's admitted with COVID and P again. So, and so the same experience in pretty much everywhere. So this is what you do on the floor, mild symptomatic patients. Think about DVT prophylaxis and continual nasal cannula. You can go to up to 6 liters, and I know this should be able to be done Zam Ethiopia. So avoid nebulization for the same reason I think Dr. Helen touched upon yesterday. So we use MDI usually. And no bagging. If you have to intubate them, avoid bagging. We do apnea ventilation. I don't know whether Dr. Ellen did go in detail yesterday or not, and avoid non-invasive ventilation. And so early transfer to ICU if you can. And if the respiratory symptoms worsen, and if they are admitted to ICU, like I said, that's when we actually start hydroxychloroquine. You need to have some kind of algorithm to go by. And I know some of you yesterday asked me if I can share our algorithm. I'll be more than happy to do that. And you can, it's on the website, it's freely available. So you have to have a protocol for your facility so that everybody has the same practice consistent. And you can also allocate your resources accordingly. This is a dose if you're interested. And anticoagulation, it's very important. Like I said, some people start a full dose anticoagulation, but we don't do. We're very aggressive on DVT prophylaxis and adding azithromycin. It's a 5-day treatment, and for the reasons as mentioned here. And broad spectrum antibiotics. So bacterial pneumonia. So co-infections are in COVID-19 are uncommon, but uncommon means like data came out of California. There was about 20% co-infection. So it's not rare, but it's not common. But if you have any suspicion or start antibiotics early, you can always de-escalate later and get your cultures, but no bronchoscopy for infection control issues. If we have to do bronchoscopy, what we do is we move the patient to negative pressure room and do the whole gadget, including N95 and goggle, and but we try to avoid bronchoscopy. And again, maintain your volume and early treatment of hypotension, tocilizumab if available for cytokine storm, and steroid is, again, it's very controversial. And because of this particular study and based on experience, a lot of facilities are now using steroids, especially in the middle to latter phase of this disease, essentially to help with this cytokine storm syndrome. This is the doses that you can use. So if you have to, when you escalate it, if you have to intubate, of course you intubate them, but you do everything to avoid intubation. We accept hypoxia up to 86%, and some of our patients on exertion, sometimes they go on coughing, they go down to low 70s. We give them time to recover. We don't rush it into intubation because of our experience and people's experience and that if they end up intubated, they tend not to do good. And you just disrupt the whole physiological response. So we try to avoid that. So we try to keep O2 saturation above 86%. The name they call it permissive hypoxemia. Our facility, we not using high flow nasal cannula, but you can use, if you do have access to it, you can use low flow nasal cannula up to 38 liters per minute. That tends to have less risk of dispersion. If you have access to prostacyclins like Flowlands, you can do trial. And again, proning, cooperative proning. And the patients are, if they are willing, ask them just lay on their belly for as long as possible. And if you have to intubate, use your expert intubators. Don't use the residents, no fellows, no students, obviously. So because you got to do it quick and the first attempt if possible, and no bagging. And of course, you got to use the full PPE. So try to avoid any crash emergency intubation. and of course, volume protective ventilation. So once they are on the vent, try to make sure that you follow their plateau pressure. I know mechanical ventilation is its own topic here, and we try to use the lowest PEEP as possible, lowest driving pressure as well. And prone, and prone. And iflow-nasal cannula, I told you about the concern. And monitoring. Monitoring-wise, so on admission, what we do is we try to get inflammatory markers, including CRP, ferritin, D-dimer. Now, D-dimer, especially D-dimer, if you look at the data out of China, D-dimer on admission seems to have prognostic implications. But on the follow-up, what we do is on admission, we obtain this and the CBC and CNP, obviously. And procalcitonin could be part of your, we don't do daily now. What we do is at least 1 to 3 days, we'll monitor that, because the CRP and especially ferritin, they tend to show you which of your patients are going to do good or not. Because increasing CRP is a good prognostic sign, and the same is true with ferritin as well. And of course, monitor QTC interval if you're using chloroquine or hydroxychloroquine, and azithromycin and torsades are uncommon, and if you can monitor them. But if you don't have access to monitoring, if you can get EKG at least every other day, that would be very crucial. And again, both of them are a 5 days treatment. We don't do routine CT scans. We try to avoid CT scans mainly for infection control issues, because if you use your CT scan for your COVID patient, then they're out for another 45 minutes or so. We don't do chest X-ray daily, and you don't need to do that. We tend to use our bedside ultrasound a lot, and that'll give us most of the information we need. But you can do chest X-rays. So really, there's no need to do CT scans on this patient that I can think of. If you have, because remember, these patients can have cardiomyopathy. So if they have any kind of hemodynamics, especially in shock abnormality, then you probably should at least get one echo. If you can get bedside echo, that would be wonderful as well. And I think that's my presentation. Thank you.
Well, thank you, Dr. Elias, for this amazing summary. I think there is a lot of questions. Before I go to the questions, I just want to invite Dr. Theodros, and I think Dr. Mola is also online. If Dr. Zarihoun is also on the line, I just want to have your additional thoughts and comments, and then we will move on to the questions. So, Dr. Theodros, any additional thoughts from your side?
Yeah, thank you. It was really excellent lecture, but I joined later, so maybe I may not be the right person to comment or to give additional information because I joined late, but it was generally what new thing I found in this lecture and not recommended in the WHO treatment guideline or protocol is anticoagulation issue. And I think it's because most of the patient has got this coagulopathy and what looks like DIC. It's good that to consider this one, just anticoagulation, and I want more information on that, what their experience is. It's mostly, he suggested that, Elias suggested that it's more of prophylactic, but do we give the full anticoagulation? And the other is what is the contribution, I have also put it in the chat, what is the contribution of these cardiac abnormalities? And I'm hearing that these cardiac abnormalities like the myocarditis, cardiomyopathy, and congestive heart failure is contributing to the death of many of the patients. And what is your experience in this regard? Is it associated with microthrombi and everything, or So I want on that. Otherwise, I really liked the lecture, and also the emphasis that as much as possible, we have to try to avoid intubation and try to manage with oxygen. And that is the way we are also, it's very helpful because we can salvage a lot of patients with providing high flow oxygens. Actually, we don't have the high flow, but we can provide oxygen with nasal or with face mask. And thank you, it was really wonderful.
Thank you. So, Elias, do you want to answer his question? I think the thought is, is the contribution of myocarditis, in the death of these patients. Is this CHF? Is this what is happening? If you can add to Dr. Teodos's question.
Okay. Yeah. So I'll say a couple of things. I know Dr. Molla and Dr. Zarioun will share their experience as well. So if you remember my first presentation, I can show that later on if you want. So cardiomyopathy with myocarditis, complication about 20%, specifically on that data, 55,000 patients out of China. So, and that is, so we do have experience with that too. Patients, one of our patient presentation of poorly essentially was troponin leak and cardiomyopathy, and found to have a pericardial effusion was tamponade signs actually. So she didn't make it. She ended up dying. So what I'm saying is, yes, cardiomyopathy with myocarditis tends to be one of the manifestations. So that's why I think if you have access to bedside echo, I think we especially if they have hemodynamic abnormality like shock, then that should be part of your assessment to see what the left ventricular function and just to see if there's any pericardial effusion. Now, we also, so you do have, so this is based on data. So, and you do tend to see this patient, and they have cardiomyopathy. It seems to be one of the common features.
So Dr. Molla and then Dr. Zarioun, if you have anything to add. And it will be nice to hear also, because there is also a question about the heart and troponin. Do you always routinely ask for troponin tests, and how do you see acute cardiac events? That would be also important to know. So if also the other intensivists could touch on that. And yes, you can briefly answer that, and then we can move on to the other organs.
Yeah, so troponin, So troponin is actually, some people follow just part of the CRP on a daily or every other day labs. We don't do that. That's particularly why troponin leak with but what is the significance of it? So because the people, it's just an inflammation without any structural disease. So yes, you can, if you have access to it, you can follow troponin. You just have to know what you're going to do about that. We don't tend to follow the troponin. We use the CRPs. They are cheaper, and they have more data to back them up. So that is my experience. So I don't use troponin daily.
Dr. Molla or Dr. Zarioun, are you online?
Yeah, so I think a few things I would like to say. Elias, first of all, it's a very good presentation, very nice summary, thank you. And regarding, cardiomyopathy, I think it's common. I mean, the virus, has, as we know, its receptor is the angiotensin converting enzyme 2. So there is a predilection or tendency to affect people who have a cardiovascular problem. And, some of the hypothesis coming out is, they are saying, again, affecting the vascular structure, specifically the pulmonary vasculature, causing vasoconstriction in some area and vasodilation in other areas. So there is a lot of interaction of this virus with the cardiovascular system. So the cardiomyopathy, typically, mild CHF-like symptom, and this, one thing we should be aware is this could be exacerbated by the ventilator itself. So, the management is not any different. The good thing is usually these patients don't get, too tachycardic. Again, their response is blunted for even while they're hypoxic. You support and you try to avoid affecting the heart function from the ventilator. So those are the things you do. And in my institution, we don't do echocardiography routinely. First thing is to avoid exposure of the patient. The person who's doing them. So unless absolutely necessary, we don't do them. And bedside echo is also very limited time that we do them. And we use things like if we have a central line, we'll get mixed venous blood gas, which can indirectly give you an idea of the heart function. And definitely troponin, we'll check at admission, as part of the lab test, we do, and we follow those, as well. So, and, EKG, we do them, every other day or so as part of the QTC monitoring, especially if we give, affecting medication. And with that, you can see a change on the EKG, serially following the EKG. So those are the things we do here, but it's pretty common.
Thank you, Dr. Zerihun. I just wanted to ask Dr. Dawud, if you can hear me, to add a little bit about the antiviral treatments Elias has brought up, and also the chloroquine issue in our institution. The reason I ask is because I think the protocols that Dr. Elias mentioned vary from institution to institution. And so maybe we need to create a repository of the different protocols we have in the US from our institutions and share them with everybody so that you can maybe customize it or contextualize it to your own institution and get a head start, at least putting it together. And so I just wanted to hear from Dr. Dawud thoughts about antivirals and chloroquine and the other medications.
Actually, one of the comments that I was going to give, good morning, by the way, everybody. Good morning, Gurma. Very nice talk that we heard. So one of the comments that I was going to give actually was about the protocols that we mentioned. There is an organization that we are building who is going to work with Ethiopian Medical Association. Actually, on the Ethiopian side, Dr. Theodros is part of that committee. So we have already started the preliminary discussion from this side. Also, we have a couple of physicians. What we are going to create is a protocol based on the many protocols that are already existing here on how to manage COVID-19 patients. So we will have that before long, and it will be part of the Ethiopian Medical Association recommendations to the Ministry of Health. And it will be there. You don't have to worry about that, because the reason why I'm saying this is even at our institutions, there is a variation of how we are treating them. I mean, we had a committee of 20 physicians from pulmonary critical care, infectious diseases, cardiovascular medicine, and hematology oncology, who vetted all available literature on COVID management for us, including published and animal model data from all time, to come up with the recommendations. So we don't have that kind of bandwidth in developing countries, so we cannot re-establish and recreate that. But we will take all this information and actually streamline it to fit to the Ethiopian context. In terms of the antiviral management, as you said, you know, HIV scientific advances have helped in so many ways, in so many viral diseases, as you know, including hepatitis C. So I would guess in a year or two, we will have a very good medication that will work on coronaviruses too. But at this time, the data that we have is really mixed. So Kaletra, which is actually sold in another name in Ethiopia, I think it is Luva or something like that. It is Lopinavir. It was the one that was first pushed to the front, but there are equal number of papers right now that says that it helps and it doesn't help. So these are the data that you're going to grapple with. The other medication, as you know, is Remdesivir, but that one, even us now cannot get it because the first high number cities already have been included in the study, and now they're not including even as Elias said it, for compassionate use, you can't even get it. So it doesn't have to be an issue. Chloroquine is going to be the savior. I had a discussion with the Ministry of Health recently, actually. They have actually, believe it or not, a big stockpile of chloroquine. So that is a big component of our treatment as we go along into that depth. But I'll talk about the oxygen supplement and things like that later. But in terms of antiviruses, it is going to be the Lopinavir, I don't remember now the trade name, and chloroquine will be the two medications. I mean, the mechanism of action almost is exactly the same, how they act on the HIV in terms of the Lopinavir. It is a protease inhibitor, so it just stops the final stage of the viral replication and processing and release from the cells that are infected. In terms of chloroquine, it's very interesting. Actually, it works on the vacuoles within the cell to acidify the cytoplasm and thereby inhibit the both entry as well as growth and replication of the virus.
Thank you, David. So Eliak, as you think about a question with regards to a medication that was used in Australia, I think it's here is from a note from Biniam. It says levermectin or levermectin. Was that something considered? What happened to it? He's asking. Is it something that is in your radar, in your armamentarium?
So I think, and again, I think he's referring to ivermectin, if I'm.
It's possible. Mm-hmm.
So, yeah, the short answer is not here. And I myself, I don't know, Dr. Dowd might have a different. I myself was aware about this like this week, Monday, about ivermectin being considered as one of them. So I think you guys will probably have more experience than we do, but no, we don't use them.
And another question that may go back to maybe Rahel. I know you touched this yesterday with regards to the airway management, and there is a question about how do you see the aerosolization risk associated with high flow nasal cannula?
That's a great question. So let me just say a couple of things then, and then I'll let the infection control guru, Dr. Dowd, comment on that. So we don't use high flow nasal cannula because of potential risk of dispersion. Now, if you look, for example, if you look at Australian guideline, they do actually recommend high flow because it all depends whether you have a good feeding or not. If you can achieve a good feeding with the high flow nasal cannula, that's actually a great way of delivering oxygen and help you avoid intubation. We are actually reconsidering our decision whether to use, but there's a lot of anxiety about it. And like I said, I mentioned the low flow type of diet, like up to 30 liters. You don't have to go all the way to 60 liters. That can actually mitigate some of the risk of dispersion if you cannot achieve. But again, like I said, some of the societies actually do recommend high flow. and they use it their main weapon to avoid intubation. So whether you don't have the technology in Ethiopia, so I don't know whether that's going to be an issue or not, but so that's what I have to say.
So, Rahel, are you on the line? Is there anything
Yes.
you want to add, particularly with the high flow issue? And also, I think you talked about the rapid sequence intubation yesterday. And one more additional thing is, what are the precautions or the additional things to do during CPR in these patients in the ICU? And everybody can chime. Elias, please, later on as well. Go ahead, Rahel.
Okay, so for the high flow nasal cannula, Elias is absolutely correct. It depends on the fitting. We consider it still a high risk setting to be in. So we do ask people entering that room, if a patient is on high flow nasal cannula, to definitely be wearing the full PPE and the N95. Okay, that's what we do. Your second question was more about the
rapid intubation and
rapid
CPR.
intubation. So the rapid sequence is extremely important, and I was trying to emphasize this yesterday, and I'm glad Elias said it today. The rapid sequence is something that's a technique used to intubate patients where we can totally eliminate the need to mask ventilate or bag. So that's why we encourage it, because we know that bagging will aerosolize the respiratory droplets in a way that's just too dispersive and unsafe. So that's the reason we do the rapid sequence with that full 5 minute of pre-oxygenation at the beginning. And it's just the safest way to do it. We also definitely want the most experienced person to do it. So it's our attendings. We're not using the residents, even if the residents are very good. We feel that the attendings are the best at intubating, and so we'll be the ones to intubate. And Elias is right. Intubation, unfortunately, eventually has to be the next step in some patients because of deterioration. But we do try to avoid intubation if at all possible, because once these patients are on the ventilator, we're seeing them stay on the ventilator for 2 to 3 weeks sometimes, which could really use resources.
Yeah, thank you. So one important comment here that goes to Dr. Dowd is actually Dr. Wendosen Amonye is online, and he said that they have locally prepared a national protocol that's released last week. So I think this task force probably needs to get in touch, and if it is already developed, not duplicate efforts, and maybe work with them and figure out. So Dr. Wendosen, do you want to comment on it?
Actually, we have already prepared based on the available evidences. And, even if the data is not really solid on the use of chloroquine, we don't have hydroxychloroquine. It's included in our guideline. And we have adopted the dose that the Chinese have used, with the understanding that it would be of benefit. But the studies I reviewed aren't really good, because the methodology has several flaws. The number of studies, the Chinese study was, most of them are observational, and it's very difficult to evaluate the effect of chloroquine alone. However, we have included, and we have also included in our guideline, the use of azithromycin. I don't think cardiac issue would be a problem, because most of our patients are young, and particularly if they are not use other cardiac medications, I don't think that would be of an issue. But if I am given the opportunity, I have few points to ask before the session ends. One of the problems is these are patients who need prolonged intubation, on mechanical ventilation. So the experience here is, ventilator-associated pneumonia is the one that kills these patients, to my understanding. So how do you deal with that? I would like to hear about the cytokine storm, the IL-6 blocker issues. Do you use any of these agents, and how do you deal? How common is ventilator-associated pneumonia in your setting? Because these patients need prolonged intubation and being on mechanical ventilator. These are the issues that I would like to raise. And I would like to hear what your responses are. Thank you.
Thank you. And so before you close, I just want, I think offline, probably David and Dr. Wondosan should connect and maybe talk about the guidelines and how you guys can work on this offline. Probably we can.
No, he is also part of that membership.
Okay.
So we are going to review it together.
Okay.
Dr. Wondosan is also on the other side. So we are all good.
Okay, perfect.
We're in the same team.
Okay, perfect. And then, you know, this is really an important issue because this has to be a very collaborative undertaking and really making sure the local expertise is part of the discussion and actually part of the decision is important. So Dr. Elias and also Dr. Zarihun, from ventilator-associated pneumonia perspective, what are your thoughts and how often do you see it?
So thanks, Elias. And I think a few things about the high flow and, you know, non-invasive ventilation. I think, you know, we have to see it, you know, I think from resource perspective as well. So, you know, everybody has been debating whether totally to avoid and so on, but everybody is now coming to a sense that we should use them because we don't have enough ventilator even in the United States. So, you know, I think that has to be considered, you know, part of it. And, you know, it's clear that there is aerosol generation and so on, but few ideas. For example, when we approve it in my institution, what we did, one, the thing Elias said is make sure that the seal is good. So, you know, you can use, you know, make sure the patient is shaved and also if he uses, you know, optiflow or high flow, that it's well, you know, sitting in the nose and that the patient keeps his mouth closed so that he would get the benefit of the high flow as well as, you know, he keeps the aerosol as well. The other thing that was recommended is, you know, to put a mask on top of the CPAP and the, you know, the high flow. So that also keeps the aerosol, you know, quantity down. So these are some of the things, you know, that was suggested, but, you know, this is something which is evolving and I think from practical point of view, probably, you know, should be allowed with, you know, question and also if available in negative pressure room. The other, I think about ventilator-associated pneumonia. So, I mean, I think, you know, these patients being on a ventilator already, you know, so far, per most of the studies, the mortality is, you know, 50% or more. So, and adding ventilator associated pneumonia really will be catastrophic. And, you know, I think the usual prevention methods, you know, we use, one of the things is, I'm not sure if the endotracheal tube that's available in Ethiopia has a subglottic suction. So as we know, the ventilator-associated pneumonia pathogenesis is from bacteria, you know, which are coming from the stomach and the mouth and, you know, go sit, you know, above the endotracheal cuff and, you know, slowly leak down. So, you know, we use subglottic suction. That's one of the key things we do. The other thing is, you know, mouth care is very important, and you know, mouths had to be washed, you know, a couple of times a day by the nurses. You know, again, all of this is a very serious consideration to expose someone to do these things close to the mouth. Because as much as possible, you should be away. So I think, you know, mouth care and subglottic suction are the key. And I think early identification and treatment are also very important. So those are the points I would say. Thank you.
Like, I think you have answered it exhaustively. So, you know, we have a lot of questions, but we don't have a lot of time. So I just wanted to throw two questions at once to Elias, and this is from, from the Hawassa group, where they are asking, you mentioned about low PEEP rather than high PEEP. If you can elaborate on that. And there is also a question about, is there some kind of a change that is happening on the oxygen dissociation curve due to this, illness that explains some of the profound hypoxemia, from physiopathology perspective.
Okay. All right. So I'll touch on that. So the PEEP, remember, so as I mentioned, so this is our understanding, and there's this consensus which came out of London a couple of days ago, and Dr. Zariun shared with me as well. So this disease tends to be different from ARDS. So compliance is not an issue, at least early on. So if compliance is not an issue, using high PEEP, it really don't benefit you. So for example, again, we will share some of our protocols with you guys if you're interested. So in my facility, we stop at PEEP of 14. We don't go any higher than that, because we agree that this is not a compliance issue. Using high PEEP really doesn't give you any benefit because it's a shunting issue. So the pathophysiology, which our understanding, every week essentially we're adding more understanding. So pathophysiology seems to be, Dr. Zariun touched upon that too, and I did as well. So more dead space creating because of microvascular and macrovascular processes, whether it has anything to do with the microthrombi or the angiotensin 2 receptor pathophysiology. So it's not behaving like a severe stiff lung, at least early on. That's why the purpose of PEEP, escalating PEEP doesn't benefit. So what we usually do is we'll start using alternatives like proning, for example, because in other ARDS, I know somebody mentioned alternative vent setting as well. They had a question about the inverse ventilation. So the role of that is also limited here, because if we're not dealing with typical ARDS, so we're dealing with more of a shunting pathophysiology. So then more dead space created. So what we do is we try to create more oxygenation space. So proning, that's why proning has a significant role. If you can use paralytics, we do use paralytics to help us with that. But again, its benefit is limited. And also, as Dr. Rahel mentioned, there's people, if they are vented, they stay vented for a long time, and you try to avoid paralytics because the high risk of critical-associated myopathy and neuropathy, and as well as steroid as well. So that's why, unless you have a good reason to use steroid, you try to avoid that. So I think that answers.
Yeah, no, thank you. And I really, really appreciate everybody's, participation. I just want to be respectful about everybody's time. And I know Elias is on duty and on call, and the same with Zariun, and I have to also run to the operating room. And with that, I just want to say, see you tomorrow, and thank you very much.